Thank you. It's always interesting to be introduced by somebody else and see what they're going to say about you. So I'll tell you a little bit about me. And also, for those of you in the back, I tend to have a voice that drops a little bit. I think it's a hazard of my profession, which is psychology. And so if it does drop off and you can't hear me, will you stand up and yell or wave your arms or something, please? Thank you. A little bit about, I'm going to add to my ambassador's introduction. I'm a health psychologist and worked for, I would say 100 years, but close to 30 years in the School of Dentistry. So I have a real attachment to the dental school. And my work there was to work in an interdisciplinary program for individuals who had chronic and acute facial pain. I worked in the TMD and oral facial pain clinic. Did a lot of teaching there and also in other parts of the dental school. My affiliation with the Center for Spirituality has continued since I've left the dental school because I just love the work they do at the center also. And I teach 2 courses there on self-care and resiliency for healthcare professionals. And the other is on ecosystems of well-being. That is how a system supports the well-being of people and how people as individuals support the well-being of a system. So that's kind of my headset, and you'll hear a little bit more about it as we progress through the next hour. So what I was asked to talk about is influencing and understanding human behavior. So there's a little bit about patient communication, but I want to start, if I can, by helping you understand and accept what are the trends in terms of patient choices about human behavior. I want you to think about how humans, including you, make choices about human behavior. I want you to think about what factors influence those choices, how we can change the way we communicate with people about the choices they make, and hopefully improve patient satisfaction at the same time. So let's start with asking, I'm going to ask you this question. What are the top 10, even if you start with the top 5 causes of death in the United States? They are heart disease, cancer, lung disease like COPD, chronic obstructive pulmonary disease. Okay, so let's just take those 3, not the rest of the 10, but we could go through the 10 if you wish. What are the major contributors to cardiovascular disease, heart disease? Smoking, diet, exercise, okay, top 3 contributors. And those are all human behaviors. We used to say, for example, I remember years ago somebody used to say, the major causes of heart disease are 30% genetics and 70% McDonald's Big Macs. Actually, one of the things we know about genetics now is we can change our genetic makeup. So that means that really more and more of it, in terms of heart disease, is related to human behavior. Okay, so let's look at cancer. Major contributors to the development of cancer. Smoking, environmental. Stress is a contributor. Genetics is a contributor. Alcohol, nutrition, exercise, right? The 3rd cause of death, COPD. Major contributors. Smoking. Behavior, 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 behavior. So, and we're not idiots as humans. We know that, right? You know that those are the major contributors toward death and will perhaps contribute to yours. That being said, during break, how many of you chose a high-fat snack? It was good, wasn't it? Yeah, okay. But you know it wasn't good for you. How many of you went outside or at least got up from your seat and exercised? How many of you sat still? Did not move? So knowing that exercise and that kind of eating is likely to contribute to premature death and chronic health conditions, why did you do that? That's an important question because that's what we have to understand about our patients also. Knowing that things are not good for us. Drug use, alcohol overuse, high-fat diets, lack of exercise, poor sleep, driving without seat belts. Those things are not good for us, and people do them all the time. Why? makes us happy in the short term, and that is something actually that our brains are focused on. They want us to have immediate pleasure. That is also reinforced by our particular culture, which says you should have it now, right? Whatever it is, now. I deserve that donut because I'm hungry and I have to sit and listen to these people talk at me all morning, right? So we have to start to think about that, not only for our patients, but also for ourselves, because we'll learn, we learn from the inside out. And so think about how it is that you make decisions about your health that will influence your health over time. So that's some of the data on physical stuff, heart disease, cancer, whatever. Do you know how many people brush their teeth on a regular basis? Half? It's actually a little more than half. Do you know what increases the likelihood that people will brush their teeth regularly? I can't hear anything, so it's coming at me. Which? Relationship. Okay, we'll come back to that. What else? Pain. If it hurts, they'll brush more. Maybe, or they'll brush less. Could happen either way. Right. Social influence is a huge contributor. And ritual. Why do you go to, those of you who do, why do you go to a religious service every week? You get in a habit and you do it over and over and over again. Now there are other reasons, obviously, also. But most people brush their teeth because they've learned to brush their teeth and they do it every day, those of us who do it. And not everybody does. They either haven't gotten into the habit, it's too painful, they have other things that are priorities, just like those donuts. We all know that smoking isn't good for us, and I'm not going to ask those people in the group how many smoke, but I suspect it's fewer. In the general population, do you know what the percentage, the prevalence of smoking is currently? 30? It was 30. It's actually less. Yeah, it's closer to 25% now. Interestingly, that percentage has not changed much in the last 20 years. It's dropped a little bit recently. Teenagers are smoking less than they used to in terms of that population, but it really hasn't changed much. And do you know what actually has the most significant impact on reduction of prevalence of smoking? Has it been the DARE programs? Just don't do it programs? The biggest reduction in smoking occurs when we raise the price of cigarettes. So what does that tell us about how people choose or make choices about human behavior? When it has a significant emotional, financial, practical impact, the likelihood of the behavior change occurring increases. That's an important thing to think about in terms of our practices as healthcare providers as well. 60%, 68% of the population of the United States is over ideal body weight. 2/3 of the population of the United States do not exercise regularly. 1/3 of the population of the United States does not exercise at all. Right? So you all know it's important to exercise. How many of you exercise more, 30 minutes a day, more days than not of the week? Right? Look around. Raise your head. Be proud. Right? Less than 1/3 of people in this room do, and you all know that that's ideal recommendations for exercise. Again, stop and ask yourself, why don't I? Because that's the question we're asking of patients. Why don't they brush their teeth? Why don't they floss? I told them to do that. Right? So why don't they? And it's important to ask that question in a non-judgmental fashion. And one way to do that is to look at yourself. Don't judge yourself. I'm a bad person because I didn't exercise 4 times this week. Why didn't I exercise? That will help you understand why patients make the choices they make also. Same thing is true for emotional issues. And then I'm going to ask you for a second to think about your patient population. But what we know about emotional or mental health issues is that probably 25 to 30% of the population in the United States struggles at some level with anxiety, depression, or some kind of addiction. And that's big. What percentage of patients actually do what it is that you ask them to do? Pretty small. And how about your population? What percentage of your population, in whatever community you work in, rural, urban, wherever, smoke? Do you have data on that? No? Just intuition? What's your guess? Same thing, 25%? What percentage of your population brushes their teeth regularly? You have that data? Intuition? No guess? 50%? How about flossing? I had a geriatric physician tell me the other day, well, the newest data is flossing isn't really that important. I asked once my residents in the TMD program, and I guess this was actually an oral surgery program, how many of the residents, oral surgery residents, actually flossed as recommended. This is a group of 9 students. 1. And she was from Denmark. So the other thing that we know from this data is healthcare providers don't necessarily do any better than their patients. With the exception of smoking, actually, we do better on smoking. But we're not any better at how we eat, how we exercise, and dental hygienists, I'm sure, do a much better job with flossing and brushing their teeth, right? I'm guessing that this is a unique population in that respect. But I'm not going to ask you to raise your hand. That would be too much. One of the models about how people do make decisions about their health care is a model called the health belief model. This was developed in the 80s. And it kind of proposed this, that people make decisions about their health based on susceptibility. How likely am I to get breast cancer, heart disease? Severity, if I get it, how bad will it be? What are the benefits of making a change? And what are the barriers to making a change? Those 4 components are things that we as humans go through when we're trying to make decisions about our health. Which of those 4 do you think which has the greatest strength in terms of influencing behavior choice outcomes? How many think it is susceptibility? How likely is it that I'm going to get breast cancer? I didn't get any for that one. Severity. If I get COPD from smoking, how bad is it going to be? Any of you former smokers? This was the rationale, former smokers or smokers. If I get lung cancer, they'll have a cure for it by the time I get it, so it's okay. It's not, it's human nature. Okay? So severity, how many think that's the strongest? Benefits, barriers. The biggest predictor is barriers. Barriers. If it's hard to make a behavior change, we are less likely to make a behavior change. So, ask yourselves again, those of you who do not exercise as recommended, why not? I know I should exercise, but, fill in the blank here, I don't have time. I'm tired. What else? Can't afford the membership. Don't feel what? Say it again. Too dark outside when I get home from work. Interesting thing is, as a psychologist doing therapy, if I'm not careful, what I listen to is the second half of the sentence, the part that comes after the but. Right? There's a saying in psychology that says, get off your butts, right? Which means don't use that phrase but. If you use and, I'm tired, it's different than I should exercise, but I'm tired. Totally different impact on the brain, right? But what we tend to do is listen to the second half of the sentence. I am tired. And then all of our focus is on, how could I be less tired? No. How could you be less tired? Exercise more, right? So our temptation is to listen to the excuses, the rationale, whatever it might be, and not to the beginning part of the sentence. So the biggest predictor is barriers. And I think that's an important thing to think about with your patients also. What is it that makes the difference? The second one is the severity. The third is the susceptibility. And the fourth is the benefits. So if we're trying to help influence patient behavior by telling them the benefits of flossing and brushing their teeth, we're going to have the least effectiveness. The most is going to be when we help them address the barriers that they're talking about in terms of why they're not doing it. Okay, I'm going to just briefly go through some of the things that we know in terms of patient variables, illness variables, treatment variables, and other things that can influence patient behavior. As you're listening, you might want to ask yourself, for your patient population or for yourself, which of these things comes up most often. So if we're looking at patient variables, one of the things that we know about human behavior is the brain has a tendency to defend against loss rather than maximize gain. So back to that donut you ate during break, right? Rather than maximize the long-term health outcomes, you said to yourself, you know, I don't get donuts that much. You know, we don't buy donuts and bring them into our house. I paid for the conference. I paid for the food. I'm going to have a donut, right? Defend against loss rather than maximize gain. So that's the way your brain will work unless, and your patient's brains will work, unless you start thinking about it differently. The other things that influence in terms of patient variables is lack of knowledge. Now, with the donuts, you got the knowledge, so I'm not going down there. But there are a lot of things that really patients do not know. For example, how to effectively floss their teeth. I got to tell you, I don't think I was in my 30s before somebody actually sat down and showed me how to floss my teeth. They told me I should, but I'm a different generation, so hang on to that. But I really did not get good education about how to floss. Right? So sometimes it's lack of knowledge. Sometimes it's lack of ability. A child really can't floss. Well, they can, but not very easily. And then a lot of times it's social influence. I actually just went to a conference this spring on integrated behavioral health in primary care medicine. And one of the focuses was on social determinants of health, which is something that's getting a lot more attention in research these days. We tend to think about patient behavior or treatment variables or mental illness or whatever it might be, but those social influences are immense. If, for example, you are homeless, or if you are addicted to meth, which I'm sure you see patients in your population who are both, the priorities are not going to be about brushing and flossing teeth. The priorities are going to be, where do I get my next meal? Where am I going to sleep tonight? Or where am I going to get my next hit of meth? So those social influences are incredibly powerful, and we tend not to give them enough attention in healthcare. So I'll emphasize that as we go along, too. These are the reasons that people defer, decline, or do not do what it is that we ask them to do. Life circumstances. I am too busy. It is too dark out. I can't afford my membership, whatever it is. The symptoms aren't strong enough. So the greatest compliance, for example, that we see with health behavior changes are with acute symptoms that are severe. So if you have a heart attack, for example, the likelihood that you will quit smoking after a heart attack is quite high. 90% of individuals who have an acute MI will quit smoking. A year later, most of them will have returned to smoking. So you get a behavior change when it's acute and high-level symptoms. If the relief is too far off, so we get the lowest compliance when we're looking at prophylactic treatment. What's your work? Prophylactic treatment. A lot of it. So what I would say about that is one of the things that we have to do then as healthcare providers is change our expectations. We expect that if we tell people to brush and floss regularly, they are going to brush and floss regularly. Wrong. So if we can accept that as data, not as judgment, we will do ourselves a favor and probably do our patients a favor also. Patients question the utility of treatment. Sometimes patients engage in behavior because it's self-protective. So recommendations, there was a procedure done years ago called a mammary artery ligation for angina, heart pain. And the surgeons claimed that it was going to take care of angina. So these were in the days you could do these kinds of studies. Some skeptical surgeons said, well, let's do a study. So they took half patients and they actually did the ligation, and the other half of patients, they went in, they did an incision, and they sewed them right back up again. We don't do that anymore. And sent them home and compared the effectiveness. Those who had the sham surgery had a much better outcome in terms of reduction of angina symptoms than the others. And there were a lot of patients who didn't want that surgery. That's self-protection, and it's a good thing. So I would think about this in terms of TMD. The implants that we used for temporomandibular joints, several of them have now been recalled. Patients have had to go back and had that material removed. Those patients who refused the surgery and engaged in self-protection did better. Heavy use of antibiotics. So there are good reasons that people refuse, not so much in the area of dental hygiene, but it's maybe one of the reasons that you find that you don't do what you're asked to do. Unclear rationale or instructions. Desire to maintain autonomy and independence, desire to maintain status quo, and one of the biggest contributors is a poor relationship with the healthcare team, which we'll come back to in a second. This relationship is such a huge piece that researchers would tell you that a poor relationship between the healthcare provider team and the patient will reduce compliance. If it's the only factor that we're looking at, will reduce compliance by 20%. So if you want to improve outcome, that's a big thing you can focus on, and it's something that you can do without any particular change in your organization. The relationship between the patient and the provider will increase compliance, if it's a good one, will increase compliance by 70%. Organizational variables. Convenience, these are things that you probably already know. If your parking isn't convenient, long length of wait for the provider, difficulty getting in, no insurance, no access to after-hours care, poor communication systems, and the physical environment, all those things influence patient compliance with treatment. The thing to ask yourself is, what can you change? Can you change, as dental hygiene specialists, can you change physical health status of your patients? No. Can you change their mental health status? No, you can help them feel more comfortable. You can recognize that they might be anxious, but unless you know something I don't know, you can't cure their anxiety or depression, certainly not in a 15 or 20-minute appointment, or at least I can't. So, so the first question is, what can we change and what can we not change? We can't change that this is female or male. We can't change sexual orientation. We can't change ethnicity or racial background. But we can change some things. We can change their understanding. We can change maybe their motivation. We'll come back to that in a second. And there are some things that we must accept. This person is homeless. This person's priority is not on their teeth, whatever it may be. The piece of that I want you to take away is the piece about understanding. If, again, you take a minute and ask yourselves, what do I understand about me? I am this age. I am this sexual orientation. I am this gender. I am of this race. I am with or without children at home. I am with or without parents at home, whatever it might be. All of those things are going to influence your choices about whether or not you engage in a certain behavior. And that's also true for your patients. The tricky part is taking the time to understand that about your people. And that's a difficult thing. So if you say to yourself, why don't I exercise? You might say, I'm lazy. That's not true. People really aren't. I would guess you're not lazy, right? Are you lazy? No. But we do have a tendency to say that to ourselves, judge ourselves. Oh, I don't exercise. Must be lazy, or must be something wrong with me that I don't do it. So understand the piece that is below the language. Okay, so we'll talk about how you might, again, begin to influence. We talk often about first impressions. And I got to say, I think dental hygienists, as a rule, make a much better first impression. Are there any dentists in the group? Than the dentist, right? The dentist rushes in and rushes out, right? So, to remember. The hygienist has, I think, a very different opportunity, probably, and also a different approach to making that first impression. But the first impression is really, really important. Humans will remember what you tell them first, what you tell them last, and what is most important to them. So when we do studies, for example, about patients who are going into an operatory, this is usually with physicians, and ask them as they leave, what do you remember from what you were told during this 15-minute encounter? You can ask yourself about your last visit to the doctor. What do they remember? They remember the first thing they're told or asked. They remember the last thing they're told or asked. And they remember what's important to them, not what's important to you or to the healthcare provider. The other interesting thing is when you ask them how much they remember of the content. So you're in there writing down all the content of the interaction between that healthcare provider and the patient. And you ask them how much do they remember. They remember 60%, maybe, content. And the healthcare provider remembers less than 30%, right? Because the healthcare provider is focused on something totally different. So your attention is really important. How long recently, in recent years, do you get when you go visit your healthcare provider? How many minutes? Do you know what you're scheduled? You go see your healthcare provider for your annual physical exam, or your first encounter, actually, with a healthcare provider. Hopefully you go annually. Right? How many minutes do you get? So this is the amount of time that this healthcare provider, if running on time, gets with you to get you, to understand you. They're scheduled 15 minutes. And they're going to remember 30% of what you tell them. That's really stunning. This person has to understand me, the context in which I live. And instead what you'll find is now healthcare systems are going through changes where they're going to ask you automatic questions. Do you feel safe at home? Right? How do you feel? So you can say, that's not an important question for me. Or maybe it is an important question for you. But they're rote questions. I mean, they just kind of go down, rather than really understanding you as a person. So understanding is much more about not do you feel safe at home, but about which do you feel, about what do you feel unsafe in your life? That's a bigger question that's going to give you a lot more data. One of the courses that I used to teach at Augsburg was for their physician's assistant students. And when they graduated, they had to memorize a list of 110 questions that they would ask their patients during an initial intake. They had to memorize the list. It was stunning to me. And that was one of the things that they had to do to pass their, one of their exams. A much better way to get information is to ask open-ended questions. In my field, yes-no questions are disallowed, with rare exceptions. Okay, where were we? So Get information by listening and listening deeply. Look at both content, what people are telling you in terms of the actual content and the context. Yes, I smoke. And in what situations do you smoke? Those things. And avoid judgment. This is one of the hardest things for those of us in healthcare because we watch recidivism and we watch things happen over and over and over and over again. We see the same patient coming in who is continuing to abuse alcohol or relapsed and is now back using opioids. And our brains just go to, oh, can't believe it. You were doing so well, right? So that judgment is really a difficult thing to avoid. And the other thing that happens with judgment is we again tend to see it, our worlds from the inside out. If you're not an opioid user, if you're not using alcohol to excess, if you're not smoking, it is hard to understand those people who are addicted, right? Any of you have family or friends who are addicted? Almost everybody knows somebody, right? And you look at those people and say, what? Why are you doing it? Just stop. It doesn't work like that, right? How about people you know who are depressed? Anybody know anyone who struggles with depression or anxiety? Yeah. And the temptation is to say, well, just get out of bed. Just go do something. Focus your attention on something else. If only it were that easy, right? If only it were that easy. It's not that easy. So our work is to get out of our own perspective. One of the best lessons I learned when I was an intern in the inpatient unit in psychiatry was there was a woman, this is when I was still a student, and most of the interns at that time, I can't remember if we were all female or male or whatever combinations, but there was a woman admitted to the unit who got her period on day one. And she spent literally all of my 8 hours there, or more than 8 hours, moaning. Oh, cramps are so bad. Oh, all day long. So what did the female interns, residents, docs do with that? Okay, what would your head do with that? Other than want to kill her. Okay, then what would they do with it? You would be saying to yourself or to her in your head, get over it. Happens every month. Move on, right? We all have to deal with it. So we ended up in a staff meeting, and we were all kind of saying that aloud or muttering this under our breath. And the male psychiatrist walked in, heard us, very astute guy, and sat down, listened to us for a while, moan and groan ourselves about this particular individual, and said, how is it that you believe that your experience of menstruation is the same as hers? That was a really enlightening question for me, because we tend to see the world like, oh, well, I get cramps too, but you don't get cramps like that, and you don't have the emotional vulnerability that she has. So it's a different experience for every person. And that was a really important lesson. So see what you can do to increase your powers of observation and decrease your tendency for judgment, which is hard. One of the things that I often say about, at least to my students, about psychopathology or mental illness, if you will, is distress is not the same as psychopathology, because one of the other errors that we tend to make is if somebody is distressed, if they are depressed, if they are anxious, if they are angry, we tend to jump to that means they are X, whatever it might be. Just because a person is upset does not mean they have a mental illness. In this case, she did too, but that's a different thing. Okay, other areas to understand. Life situations is what I was talking about earlier in terms of homelessness, poverty, access to health care, other situations. 60% of health-related challenges are proposed to be related to life challenges, not to anything else. Degree of distress. So how distressed is this individual about whatever is going on? You might be more distressed about their periodontal disease than they are. Degree, and often are, right? That maybe I should take out the may next time I use that. Degree of disability or malfunctioning. So how is this impacting activities of daily living? If it's not, you're much less likely to observe a behavior change in a positive direction. Risk of future suffering if left untreated. And then patient attitude and preference for treatment. In the area actually of mental health, psychology majors would remember this, that when we look at abnormal or psychopathology, which I don't even like either of those terms, those are the three areas that we look at. How distressed is this individual? How disabled is this individual by whatever is going on? Their addiction, their depression, their anxiety. And what is the risk if left untreated? So we might actually apply distress, disability, and risk to other areas of healthcare as well, including hygiene. The last piece is patient attitude and preferences for treatment in the TMD clinic. In the TMD clinic, we did a typical assessment. One of the assessment questions that I always asked people was, what is it that you believe to be the reason that you're having this pain, for example? And patients will come up with a lot of different things. I think I have a joint problem. Okay, where are you feeling the pain? Here, right? So what does that tell us? There's a little lack of understanding there. There's no joint there, obviously, right? And then the other question I asked, well, okay, well, given whatever it is that you believe, I have my TMD problem or whatever it might be because of stress, right? So what would the treatment be then? Well, I think I should have surgery. I have the problem because of stress, but the treatment is surgery. I don't think that's going to work, right? So we need to ask what patients' attitude or hypotheses are about what it is that they're experiencing, and then what their preferences are for treatment. Why would they choose surgery? What is the belief of a patient who would choose surgery in that? Say it again? That'll fix it, take care of it, easy fix. Surgery is an easy fix. So how about those of us who have joint problems? What's our answer? Nobody has joint problems here, I'm sure, but those of us who might. Surgery. We could have surgery. We could have cortisone shots. We could get addicted to opioids. We could take a lot of Tylenol. Or we could exercise. Just an option. Just an option. Okay. So I can tell you a little bit about this data in case you need it for your practices. But again, and you probably know it, prevalence of anxiety in the United States is about 33%. For those individuals who have dental-specific anxiety, it's much lower than that. And there are numbers of people who have dental-specific anxiety. And we should also recognize that most patients who are coming in for dental treatment or coming in for an appointment have some level of anxiety about that to begin with. We also know that about healthcare in general. That's why when you take blood pressure, when patients first come in, it's different than when they've been there for 5 or 10 minutes, right? Okay. So you can assume certain level of anxiety. Mood is a little different. The prevalence of depression in the United States is about 20-25% in that range, again, depending on the population. Some interesting things about mood and depression. They're also age and gender specific. So we tend to diagnose anxiety and depression more frequently in males or females? Females. And the data would suggest actually that in children, we see much higher prevalence of depression in male children than in female children. Hit puberty, that switches, and we see much higher prevalence in women during childbearing years. Hit menopause, and it switches back again. Might there be something to learn about that, or to be learned about that? Thinking. The other interesting thing about anxiety is that, I don't know if any of you had a panic attack? 40% of women during childbearing years will have a panic attack. And most of them will have only one. But it's kind of scary when you have it, isn't it? 40%, which tells me, at least, that there may be some hormone influences there. Okay. Mood is about negativity, pessimism, and hostility, which you will see in your practices as well. Okay, so some things about compliance that might be helpful. Again, we're just looking at data here, no judgment. 30 to 50% of individuals do not comply with recommended treatment. A third to a half fail to keep their appointments. Again, ask yourself, is this also true in your practice? 40 to 75% don't follow instructions about use of medication. 45% drop out of lifestyle programs, for example, exercise programs or quitting smoking programs. The seatbelt use is probably a little high because now it's mandatory in all states, but nationwide, about a third don't wear seatbelts, and 2/3 of the population don't exercise regularly. 45% of the population don't exercise at all. With the exception of tobacco use, we don't typically do any better than our patients. And if you look at compliance with standards for the profession, when that is studied, the standards for various procedures ranges about 50 to 72% below standard. And again, you will probably recognize this in your own profession as well. It's nice that we set our standards high. It's not nice that we don't meet them. So, non-compliance. So look at your patient population again. Kind of go back to what you know. If I were to divide, okay, these are patient variables. If I were to divide it into age groups, children, adolescents, middle age, and elders, which of those 4 groups do you think are most likely to comply with recommendations, which of those groups are most likely to do what you ask them to do? Okay. How many think children? Adolescents? Good call, adolescents. You didn't either. Middle-aged? Elder. Elder actually tend to comply the most, and they also report the least amount of pain, which is kind of an interesting thing. It follows the pain threshold also. Women or men most likely to comply? Women, why? Well, we could pat our egos on that one, or we could say that women, especially women of childbearing years, which is many of our years as women, tend to comply because there is a reason to go see a healthcare provider, and there are some things that we want to do to protect ourselves and our children, right? So a different kind of motivation than there are for men. Race? Is there? It's less about race specific than it is about ethnicity. There are some cultures and subcultures, like my Danish oral surgeon. I remember visiting her years later in Denmark, and you know, it's 11 o'clock at night, there are no cars on the street, we hit a stoplight, and it's red. Look around, nobody here. Why wouldn't I walk across the street? I step off, and she's like, you stay here until the light turns green. I go, okay. So there are certain cultures that emphasize compliance more than others, but it's more about culture than it is specifically about race. SCS in education, are people who are more educated more likely to comply? No. Personality absolutely is a factor. And life circumstances, absolutely a factor. It's more about life circumstances than education that influences compliance. Treatment variables. The more complex the treatment, the lower the compliance. The more intrusive the treatment, the lower the compliance. The longer the duration of treatment, the lower the compliance. The poorer the relationship with the healthcare provider, the lower the compliance. So again, if you are providing a treatment that is complex, intrusive, or long in duration, like brushing teeth and flossing teeth, you're likely to have lower compliance. Illness variables, these are the ones in terms of prophylactic treatment. We get lower compliance with prevention than we do with cure. The lower distress, the lower the compliance, and the poorer the prognosis, the lower the compliance. So why is it that we struggle so much as healthcare providers with understanding this about our patients? One is personal differences. I just don't get it. I do not understand addiction. Well, how many of us do understand addiction? People who've struggled with addiction get it. those of us who have not struggled with addiction, we have a much harder time understanding addiction, correct? Difficulty remaining non-judgmental. Because we don't understand it, we often judge it as lesser than. And this is also true with respect to individuals of the opposite sex, people who have different sexual orientation or gender identity, people who are of a different racial or ethnic background. I don't understand Muslims, right? So if I don't understand them, and I don't try to understand them, I'm going to have a much more difficult time engaging in a relationship with someone from that religious or ethnic background. If I find something out about a patient and the other hygienist who's working with that person a year ago found out something else and I can't reproduce those findings, that challenges my ability to understand that person also. We have difficulty accepting patients' despair, their anger, their distrust. And we also engage in what psychologists and social psychologists call errors of imagination. We engage in premature closure. One of my colleagues, a faculty at the dental school, we were reviewing a case, and the comment he made was, well, that person is an MA patient and they're all alike. So this is what we can expect. That is premature closure. Therefore, the assumption was that individual was not going to comply with treatment and not going to do well. Tendency to fill in the gaps. In other words, we don't have all the information, so we'll put some in that might fit or might come from our own experience. Failure to recognize that things will look different once they happen. There's some interesting research on if you win the lottery, how do you think you will feel a year from now? It's a pretty big lottery these days, right? So you win. How do you think you're going to feel a year from now? Happier than you feel now? We think so. A year later, happiness ratings on people who come into unexpected wealth like that, pretty much the same as they are a year earlier, right? There's an initial bump, and then we come back to our pre-event status quo. And we also have a tendency to project the present into the future. It's a wonderful book and actually a cool YouTube video called, I'll have to come back, but goes through some of those different things. So understanding. We have to know what the patient believes is the reasons going on, their expectation and preferences. Prediction of adherence. I always won the lunch bets in the TMD clinic. Patient would leave, and we'd say, well, how likely is it that this person is actually going to do those jaw stretches? I won 100% of the time, right? So we'd bet. Why did I win? Because I have an insight that they don't have? No. Why did I win? Because I asked, how likely is it that you're going to do those exercises? Right? Gives you a lot of data really fast. Just ask, right? Know the person's overall health status as well. That kind of goes. Good understanding is be able to identify the factors thought to contribute to the disease, identify the factors that can negatively and positively influence behavior change. All right. That's the piece about understanding, and you'll note that I spent most of the time talking about understanding because understanding has to happen before we can influence. If we're going to influence, you might want to focus on these things we call the 5 A's. What's the patient's agenda? Assess what's going on. Advise if asked. Okay, unsolicited advice to your teenager, how does that go over? Not so good. Assist and arrange follow-up. In fact, my son just said to me the other day, came in and was complaining about his back was hurting, and of course, what am I going to suggest? Well, have you tried some exercises, or do you need to do some stretches? He said, I just want you to listen. Like, oh, forgot. Okay. Address, assess, advise, assist, and arrange for some kind of follow-up. The importance of language is critical. If you do not speak the language of the person, the native language makes a difference. I used to talk in the dental school about dentalese. Patients would come in and talk about, dentists would come in and say, talk to a patient about internal derangement of the TMD, right, of the TM joint, and I'm going to refer you to the psychologist. internal derangement, refer to psychology, right? So the language is super important. Look for precision, ask open-ended questions, avoid those yes-no questions anytime you can, and consider the hypothesis of the patient first. Remember that every appointment is an interview and an opportunity to gain more information. Influencing is about being genuine, taking time, and striving to figure out how this particular person is unique and different. Not like everybody else, but different from everyone else. If we go into each patient encounter with that question, how is this person different and unique than everybody else I saw today? We will gain a lot of information in a very short period of time. And we will improve the relationship between ourselves and that particular individual. Patients want to know what's likely to happen during the appointment and after. Patients want to have a cognitive sense of control. I have there's a teacher in psychology, Aaron Beck, who talks about, and he's a cognitive psychologist, and he said humans struggle over and over again with kind of three basic principles. We struggle with, we are not good enough, right? So we're looking for data that supports we're not good enough unless we change that. We are not lovable unless we look for data that confirms that we are lovable. And we're helpless. So the more information we can give to patients about how they are good enough, we don't have to talk about lovability in the dental chair, but they do have some kind of control, that they're not helpless. Those make a difference. Patients also need to have a sense for what the intervention is going to feel like. My daughter hated having her teeth cleaned because she didn't like the vibration on the teeth. I never would have anticipated that because it didn't bother me one bit. But she wanted to know each time, are they going to do that? So have a sense for what the intervention involves and have time to decide. Remember that the patient is anxious and address that. Give information first and then advise if you're asked for advice. Remember, silence is okay. It's a hallmark of my field. Let people sit with what they feel and what they're expressing for a period of time. As a rule, an authoritarian approach is not well received. Any of you parents? Right? It's the same with your patients. The other thing we sometimes forget in healthcare is to reinforce and compliment. Because we assume that patients should do what we ask them to do, we fail to reinforce it. It's kind of like, oh, my child should know to say thank you. And so we forget to reinforce them with a hug, a smile, eye-to-eye contact, and let them know that you appreciate that they thank their grandparent for that gift or whatever it might be. If you are going to reinforce, and hopefully you will, remember that a reinforcer has to be of value to the particular person. So a reinforcer is not defined by you. Some dogs, any of you have dogs and train your dogs? Some dogs really love cheese. Some dogs really don't love cheese so much, right? Some dogs are very food-oriented and some dogs are not. So if you are training an animal, you have to figure out what is reinforcing to that animal. Same thing for humans. If you want to increase the likelihood that a behavior occurs, find the reinforcer that's of value to that particular person. It's not always a sticker. The reinforcer must follow immediately after the desired behavior, not hours later. And it must be, it's more effective when you pair it with some kind of social interaction. So if you want to reinforce your child for a good behavior, rather than just saying good boy, good girl, if you reach down, make eye-to-eye contact, give them a hug and say, I really appreciate what you did, it's a much stronger reinforcer. This is a model, and I'm not sure how I'm running on time because the two clocks say different things, but this is a model that talks about change. Are you familiar with this model from somewhere else? Trans-theoretical model of change. Ambassador, can you please tell me how many minutes I have left? Do you know?
The next starts at 1, but I don't know how long.
Okay, but am I going by that clock? Okay. This is a model that talks about how people make changes called the trans-theoretical model of change. It was proposed by two researchers who are actually working in the tobacco cessation field, DiClemente and Prochaska, and they said what happens is people engage first in a pre-contemplation stage. So if you're talking about tobacco cessation, for example, pre-contemplation is they're not even thinking about quitting. Contemplation is they're thinking about quitting. And and so on through the wheel. You can exit or enter at any particular point, but the question is, can we actually, as healthcare providers, influence movement from one stage to another? Can you influence people to move from pre-contemplation to contemplation? Initially, 30 years ago, we'd say no. Lack of motivation to change is not a treatable condition, was what my mentor told me. The later research suggests that we actually can make change. And one way to make a change is to engage in what's called motivational interviewing. Do you know that phrase? You've heard about that? Okay. So if, for example, you're doing an assessment and you ask the question, are you a smoker? Right? And the answer is yes. And you then ask what question? How much do you smoke? Okay, so I smoke a pack a day. Now what do you do with that? You write it down on your piece of paper and do what? You go to the next question. Or you could stay with that question and say one simple thing. When did you last think about quitting? That can help people move from pre-contemplation to contemplation because it prompts the brain to say, think about quitting, think about quitting, think about quitting. So simple intervention like that actually can make a difference between pre-contemplation and contemplation. And moving people from contemplation to that earlier stage, the next stage, is about values clarification. Why would you want to quit? What is it? What value would drive you to move down the wheel to a different kind of behavior change? One of the errors that we make is we don't tell people what to expect. We don't take the right action. We advise when we should be listening. We take the wrong action. We advise when we should be listening. Or we take action at the wrong level. So those are the 4 most common errors that we make as healthcare providers. And they do not do a good job of helping move people through the behavior change. If we are to be more effective at influencing patient behavior change, we have to ally with the patient, which means we have to understand him or her, or them. We have to reevaluate at each appointment whether or not the patient is continuing to endorse the plan that we propose. Do they still want to work on flossing, or now do they want to focus on something else? We need to explain clearly any changes that we see or any changes in the plan. We need to develop small steps, you know, those baby steps. They're very effective. And we make specific and positive requests. We say, how about start doing rather than stop doing? Stop smoking, not as effective a message as start exercising more. Start engaging in breathing exercises. Keep the goals specific and simple. Assess for understanding. Teach problem-solving skills. When you run up against a barrier, what will you do? All my friends are going outside to smoke. What will you do? Teach coping skills. Teach self-reinforcement skills. This is a thing that we often miss also in healthcare providers. So how can you pat yourself on the back today when you go out during break and walk around a little bit and stretch? Or when you refuse the second cookie, right? How can you reinforce yourself? Assess practical issues at each appointment. Give more than one choice. You could have a cookie or a second apple today, right? And engage social support. That public commitment and social support is a huge piece. If you exercise with somebody, you're more likely to continue your exercise program, right? Good influence looks like improving ability to engage in self-care. It will include improvement in the patient's quality of life, patient's understanding of the relationships between behavior and health. It's tailored to the specific person. So we talk in psychology about tailor and teaming. So you're much better off if you tailor treatment because you understand that person and you know what's unique about them. Tailor treatment to their particular unique situation, and then team up so that all members of the team are addressing that issue. So the summary. First, concentrate on your relationship. Understand what's unique and build that connection. Second, take time, take time, take time, take time. 15 minutes is not enough to understand a person, right? Years are not enough to understand a person. I mean, it's hard enough to understand ourselves. Listen, listen, listen. Silence is okay. Open-ended questions will give you more data than yes/no questions. Know what the patient believes is going on and what they prefer, and then focus on skills, not on deficits. Tailor treatment, become a good teacher, maximize what I call non-specific effects. In my field, I don't have tools other than language and non-specific effects. I have relationships, and it's a huge influence on patient behavior. And use the team. All right. Does that give you enough information in a very short period of time on understanding and influencing? Thank you very much. Happy to take questions.